One, we are live.
Welcome. I am Dr. Vinita Ramnani, Secretary, Bhopal Divisional Ophthalmic Society. I just welcome you in this webinar on interesting case of retina. We have two eminent speakers with us, Dr. Devdulal Chakravarti, in charge Vitreoretinal Services at Disha Hospital, Hooghly, and Dr. Santosh Gropikrishna. He is a consultant at Narayan Nethralaya, Bangalore. So I welcome both the guest speakers and our panelists, Dr. Swarna Bisaria Gupta, Madam, and Mansi. Because of their illness, they could not join, but I welcome Dr. Chawla, Dr. Som, Dr. Ashish Atle, and all five speakers, Dr. Ridhima, Dr. Paresh Nichlani, Dr. Fazil Khurram, Dhiren Singh, and Nazia Sheikh. Dr. Lalish Srivastav, because of some issue, he is not able to join us. He will be joining soon. So we are starting this webinar with a first keynote address from Dr. Devdulal Chakravarti. He will be presenting Changing Treatment Paradigm in NMD Global to Local. Dr. Devdulal, please, sir.
Thank you, ma'am. Thank you for the introduction, and thank you, BDOS, for this kind of opportunity. It's nice to meet all of you, many of my friends and seniors, and warm greetings to all of you from here in Disha and Kolkata. So I'll be sharing my slides, and I hope you can see them. I'll go full screen. Are my slides audible and
yes,
say visible, and am I audible? Yeah.
Yes, okay. You can go ahead, please, sir.
Sure. Thank you so much. So I will be speaking on changing treatment paradigm in neovascular AMD from global to local. So basically, I have no financial interest in this. So anti-VEGF usage changed the outcomes of retinal vascular diseases, and this is something that we all know, that we last century we started off something like this. Most of the AMD patients and other retinal disease patients would have some kind of vision like this. And then actually with the advent of anti-VEGFs, there has been a substantial reduction in blindness across the world, especially when it comes to retinal diseases. Now, probably the game changer, if we can call it that, was ranibizumab, which actually was the first anti-VEGF molecule to be actually approved by the FDA and subsequently by the other bodies in different countries. So what actually changed with ranibizumab was that there was consistent 12-month visual gains with ranibizumab in treatment of retinal diseases that was noted. And if you talk about neovascular AMD or diabetic macular edema or central retinal vein occlusion, branch retinal vein occlusion, and even myopic CNV and to some extent in ROP also, this drug ranibizumab actually was the game changer, and people started getting better vision in various types of retinal diseases, and their vision could also be maintained. Now, problem is that neovascular AMD is a long-term disease. It's not a one-shot injection that can solve the problem. So what these people require is consistent treatment to maintain vision outcomes. And getting an injection every month is something that is quite difficult. So what happens is actually some of these people drop out from treatment, and what actually happens then is that they lose vision. So if a patient drops out of treatment for 1 year, so you can expect 41% of these lesions to go bad, to be reactivated. And if these patients actually do not get treatment for 5 years, then almost 80% of these patients are surely going to get worse, much worse vision, and many of them will not be able to even have reading writing vision. So it's important that continuation of anti-VEGF therapy, even in stable patients, is something that is necessary. The other important problem is that not all eyes respond in similar fashion to one drug or maybe a couple of drugs. So when patients don't respond or have lost responsiveness, treatment decisions become even more challenging. So we know that regarding anti-VEGF therapy, some patients can be termed as good responders, some can be termed as partial responders, some are poor responders, and some are non-responsive to a particular anti-VEGF drug. So we are in dilemma in such a situation when there is poor or non-response, or maybe a partial response, and we have to look for some other drug. So the important thing here is that there have been lots of publications which have shown that if you have fluid in various retinal diseases, be it neovascular AMD or diabetic macular edema or retinal vein occlusions, so what happens is there is increased likelihood of loss of vision, and there is increased likelihood that these patients with intraretinal fluid or subretinal fluid are likely to come back again and again to the ophthalmologist, treating ophthalmologist or the retina person, and they will need much more frequent treatment. So it's not a very good situation for the physicians who actually want something more efficacious, the treatment part that is should be more efficacious, and the monitoring burden should also be less. And if you talk about the patient's perspective, from the patient's perspective, they also have unmet needs. They are concerned about the vision improvement that might not be there, and frequent treatment intervals is something difficult for the patients, because they have to come in to the hospital, maybe bring in a caregiver, which might be from the family or someone else who has to miss out on his or her particular kind of work that he is doing. So patients' lives are preoccupied with frequent clinic visits in many of these diseases. So this is where the world of the patient and the physician meets. And so both of us, we want effective treatment, we want lesser injection visits, and we want lesser monitoring visits also. So this is where evolution of anti-VEGF is something necessary. So we started off with pegaptinib, then we had off-label bevacizumab, which is still in use, then of course ranibizumab, the game changer, then came aflibercept in the early part of last decade, and then of course brolucizumab recently, which was approved by FDA in 2019 and by the Indian DCGI in 2020. Now, what is so special about this new molecule is that it's a single chain fragment antibody with a very small molecular size of 26 kilodaltons, and it is this small molecular size which probably does the trick. It allows deeper penetration into the retina, it allows faster onset of action, greater molar dosing is possible, and to add to it, lower systemic concentration has been noted with this drug. Now, if you look at a comparison of the therapeutic response between brolucizumab and aflibercept in Hawk and Harriet trials using deep learning-based OCT analysis, what we see is that brolucizumab is capable of extensive decrease in intraretinal fluid following the first dose of the drug. There is superior subretinal fluid resolution that is noted with brolucizumab, and there is more pronounced PED resolution with brolucizumab. Now, there have been subsequently multiple real-world publications that have come out following the approval of brolucizumab across the world. So these three studies are from other countries, and there wasn't much Indian data that was available. So this is what got us kicking, and we published the BRAIL study. And all these studies have something in common: superior fluid resolution and increased treatment interval, that is increased time between the injections. So this is something common with brolucizumab. So basically the BRAIL study, if we move on to the results straight away, this was predominantly a male cohort that we were treating 63:31. The total number was 94. And the mean prior anti-VEGFs in previously treated eyes was 8.63. The mean number of brolucizumab injections was 1.36, and the mean follow-up was 7.3 weeks. And the interval between brolucizumab injections was 10.2 weeks. Now, talking about the visual acuity part of it, the full cohort had a baseline visual acuity of 2120, which moved up to 2093. So this was statistically significant. And so also was the central subfield thickness in the full cohort, which improved from 408 at baseline to 281, which was, of course, significant. Now, if we talk about fluid characteristics, which is what brolucizumab is kind of famous for, subretinal fluid was noted to resolve in 15% at final follow-up, and almost close to 80%, 78% to be precise, at the final follow-up was reduced. And intraretinal fluid, which is something that we really don't like, most of us don't like, so almost close to 40% of these patients did not have intraretinal fluid at final follow-up, and it was reduced in 46% of these patients. Now, you're talking about PED, which is something that was previously kind of difficult to treat. With brolucizumab, 23% of these Indian eyes had resolution of PED, and it was found to have reduced in 61% of the eyes. Now let's look at a couple of illustrative cases which were there in this publication. So this was a 64-year-old female naive lady that is with a large SREM and subretinal fluid, and she presented with 20/100 vision. So by 1 week post brolucizumab, you can see the SREM is already melting up, the SRF is almost gone. And by 2 months, remember she was on a PRN regimen and she had received only 1 injection so far. So she went up to 20/60, and as you can see, the CNVM complex is shrinking up and there's no fluid. Now, this is what happened 12 weeks post the first injection. The patient actually had 20/30 vision, and you can see a little speck of him coming back here. And so this is when we advised the next injection. And this is in fact 12 weeks post the second brolucizumab injection. She was doing 20/20 partial. And, like the Hawk and Harrier would tell us, more stable inactive lesion in the subretinal space where the CNV localizes. Now let's look at the other example. This is a 70-year-old gentleman post 11 anti-VEGF injections in the left eye with a baseline vision of 20/200 before being inducted into brolucizumab therapy. And so you can see there's a lot of subretinal fluid and intraretinal fluid, and this is the octa which shows some activity. So this is post 1 week following the brolucizumab injection. You can see the SRF already going down, and this is at 1 month. A little bit of intraretinal fluid and subretinal fluid is still there. And we followed this patient up, and by 4 months, we could see that the intraretinal fluid was, increasing. So this was the time when we had to take a call for the next injection. But what actually these 4 months told us that, there was longer duration of action that was evident, and probably because of the greater molar dosing that is possible with the smaller molecular size of brolucizumab. So this is what happened after 1 month of the second brolucizumab. The retina looks really nice and neat, and there's no fluid here. And as you can see, 3 months post the second brolucizumab also, there's hardly any fluid here. And by 4th month, what we could see was that again the fluid was coming back, the intraretinal fluid and the subretinal fluid. So we injected the patient again. So this is again evidence of the long-term kind of longer interval that is possible with brolucizumab. What about adverse events? Many of us have read about or we know about the adverse events that are sometimes possible. So what we had was RP rape in one patient, and this is something that we subsequently published in the Indian Journal of Ophthalmology also. And we also had a couple of cases with subretinal hemorrhage following the injection. Now, what are the causes of the lesser number of intraocular inflammation that is noted in the Indian population? Probably genetic cause of lesser IOI in Indian population is something that we really need to think of, and we published on this. And also we used a PRN regimen as opposed to the standard monthly loading dose that is kind of mandated by the Hawk and Harrier trials. So we've been using PRN regimen for brolucizumab, and we've published these 3 other articles also. These 2 are on diabetic macular edema, and this is on polypoidal choroidal vasculopathy in Indian eyes. And this is a publication that's going to come up in the Indian Journal of Ophthalmology. It has been accepted, and this is the final proof that I'm kind of giving you a sneak peek. So here also, we found that brolucizumab is safe and effective in controlling PCV in both treatment-resistant and treatment-naive eyes. So to conclude, the decision not to initiate a new drug is heavily influenced by who says what, but the decision to adopt a new drug is clinched by the subsequent personal clinical experience. And to that end, I would like to share that we in Disha have used almost more than 950 vials. So if I remember right, probably around 9,000 to 10,000 vials of brolucizumab have been used in the country, and we have used almost 10% of those vials. And various indications like neovascular AMD, recalcitrant DME, and recalcitrant RVO have been treated with this drug, and all these patients are really doing good. So thank you all for your kind attention, and I'll stop sharing.
Thank you, Dr. Chakravarti, for such a nice elaboration, and especially thank you for showing your all studies which are published. Now,
Thank
with
you,
this, if you have used so many brolucizumab, what is your drug of choice? Like, do you consider it as a first line of treatment for all your patients of NMD?
Yeah, that's a very important question, ma'am. So, like like you mentioned, brolucizumab is a drug that is approved for usage in neovascular AMD at this point in time, and not for other indications. So, when a patient of neovascular AMD comes to me, so I make sure, or this is the hospital protocol, that we make sure that none of these patients have anything to do with any kind of inflammation. So if the patient has inflammation or has history of some reaction to an anti-VEGF injection prior to this particular visit, then he or she is not going to be injected brolucizumab. The other important thing that we do is we look into patients, as all of you do also, properly on the slit lamp, and also the indirect ophthalmoscope has to be done for any patient that we inject with brolucizumab. And what is why this is essential is because any patient who has the slightest inflammatory signs, which can lead to such a situation of inflammation post injection of the drug, these are people who don't get brolucizumab. Then coming to what is the choice of drug for us in Disha, we offer a basket choice to all patients. We do not use Avastin. We have not been using Avastin since 2014, when we had some cluster endophthalmitis. So other than Avastin, we offer the patient all these drugs with all their side effects and benefits, and are told to the patient. And so it is for the patient to choose the particular drug. We offer the whole basket: ranibizumab, biosimilars, aflibercept, and brolucizumab. So it is the patient who ultimately is the deciding factor.
Good evening, sir.
Yes,
Sorry. No, I just wanted to ask Dr. Chakraborty that you've been using brolucizumab for off-label, as an off-label drug for your recalcitrant DMEs and RVOs. Do you have any special consent form for those, or how do you counsel your patients?
Yes, it's kind of similar to what we use for Avastin, what we use for IVT. IVT is also off-label. So we don't use Avastin as of now, but it is something similar. And we tell these patients that you can have these issues with such and such drug, whatever drug we are using. So with Ozurdex, maybe you have a chance of raised IOP. So these are things that need to be told to the patient.
So one more question which I would like to ask is, with IOIs, you have do you follow a particular protocol for your patients, like when to look and how long to look for IOIs?
Actually, we go PRN with brolucizumab, but the issue here is we actually see these patients within the first week once, and then every 4 weeks. So doesn't matter like whether the patient is dry or whatever. We ask the patient to come back after the first visit every 4 weeks. So this is something we insist on, and we tell these patients that you can have issues if you don't visit in time. When we started off with brolucizumab, what we did was, we, in between this 1 week and 4 weeks, we actually called up all these patients, not me or not, my colleagues, but, our support staff. We made them call up these patients and find out if anyone was having any redness or pain or any floaters or anything that seemed fishy. So, we were very, very careful when we started off. Now with time, with, some amount of, experience, we are kind of becoming more confident about the drug.
And so you are giving loading dose also with brolucizumab?
No, we haven't given any loading dose to any patient with brolucizumab. No loading dose. We are going strict PRN for recalcitrant, for NIVE.
Thank you, Dr. Chakraborty.
Thank you,
we will move to our case presentations by BDOS members. So in this series, there will be 3 presentations. The first will be by Dr. Ridhima Deshpande. After that, Dr. Paresh Nichlani is going to present, and Dr. Fazil. And once we are over with this case presentation, then we will have that again a keynote address from Dr. Santosh. So Dr. Ridhima, you can share your screen and present your case in 5 minutes.
Is my screen visible?
Yes, Ridhima, you can go ahead.
Good evening, everybody. At the outset, I'd like to thank Team BDS for this opportunity. Today, I'm going to present a very interesting case of presumed ocular tuberculosis. So this was a 44-year-old female who presented with sudden onset diminution of vision in the right eye for 15 days. And there was associated pain which aggravated with extraocular movements. There was no history of preceding illness. On examination, the right eye visual acuity was 21, 20, and 12. Left eye was 20, 20, and 6. Intraocular pressures were normal. The anti-segment evaluation was normal in both the eyes, except for the fact that there was RAPD in the right eye, and it also had defective color vision where the patient could barely recognize the demo plate. So this is a fundus photograph, which showed disc elevation, macular star, some retinal striae, and vascular tortuosity. And the left eye fundus examination was normal. With this, we made a provisional diagnosis of right eye neuroretinitis, left eye emmetropia, and we ordered fundus fluorescein angiography, OCT, ultrasound B scan, and blood investigations to rule out systemic diseases. On investigating, her total counts were elevated. There was monocytosis on differential count. The chest X-ray was normal. ESR was elevated. MON2 was strongly positive with a 20 by 20 millimeter induration. The quantiferon TB gold was positive. Serum ACE, HIV, VDRL, toxoplasma, IgG, and IgM were within normal limits. So we revised our provisional diagnosis to presumed ocular tuberculosis in the right eye, left eye emmetropia. But when we ordered an OCT, there was this big choroidal bump in the right eye. And although there was no subretinal fluid, there was some inner retinal folds. And on B scan, there was significant choroidal thickening. There was also this nodular lesion, which could be seen on one of the transverse scans. And if you look carefully, there were some pockets of subtenon fluid as well. On angiography, there was early hyperfluorescence in the area which showed inflammation. The rest of the fundus had normal fluorescence. And there was a hot disc, and we could see some areas of pinpoint leaks along with some dark striae all around the disc, probably indicating presence of choroidal folds. So again, you can see the pinpoint leakages all around in a hot disc. So all this pointing to the presence of posterior scleritis. So then we revised our diagnosis once again to right eye posterior scleritis, secondary to presumed ocular tuberculosis. We know that ocular TB is an infection by Mycobacterium tuberculosis, which can affect any part of the eye with or without systemic involvement. It is an extrapulmonary form of tuberculosis, most commonly acquired by hematogenous spread, which is secondary, although primary tuberculosis is also seen. It's a great mimicker of various uveitic entities, and prevalence of presumed ocular TB in India is 0.4 to 9.8%. And one of the studies, POTB, presented as posterior uveitis in 42%, anti-uveitis in 36%, pan-uveitis and intermediate uveitis in 11% of the cases. The diagnosis of POTB is based on presence of one or more of the clinical signs, along with either a positive MON2 test or evidence of confirmed extrapulmonary or pulmonary tuberculosis, along with a positive ATT trial, after excluding other uveitic entities, and also keeping in mind the endemicity of the disease or history of recent exposure. Diagnosis is confirmed only by either demonstrating the organism itself or its DNA from the ocular samples. Posterior scleritis is uncommon, reported in only 2 to 12% of all cases of scleritis. Tubercular posterior scleritis is even rarer. It is associated with systemic diseases in 29% of cases. It is usually unilateral, more common in middle-aged individuals, more so in women as compared to men, and could be of diffuse nodular or necrotizing variety. Causes could be non-infectious and infectious. Non-infectious, just connective tissue disorders, vasculitis, sarcoidosis, porphyria, and infectious causes such as herpes, TB, syphilis, Lyme's, nocardia, streptococcus, etc. There have been a very few reports in literature where posterior scleritis has been associated with systemic tuberculosis. A workup of posterior scleritis usually involves a complete systemic examination, such as TB, CBC, chest X-ray, TST, QTB, ACE, HIV, RPR, rheumatoid factor, ANA, dsDNA, and serum ANCA. Imaging for posterior scleritis includes an OCT, which usually shows subretinal fluid, choroidal thickening. The USG-B scan can classically show the T sign. FAICG can show areas of pinpoint leaks and pooling of the dye, and CT orbit to rule out orbital inflammatory disease or space-occupying lesions. This patient was referred to the pulmonologist to start antitubercular therapy, which was advised for 8 months, along with concomitant oral steroids in a dose of 50 milligrams per day for 2 weeks, followed by a slow taper. This is the 1 month follow-up of the patient. The right eye visual acuity was 20/50. The choroidal bump that we earlier saw in OCT had reduced. The choroidal thickness had reduced. The nodular lesion that we earlier saw had resolved. The subtenon fluid had also resolved. She was advised to continue ATT and taper steroids further. Again, on the second week follow-up, the visual acuity was stable. The choroidal thickness was back to normal, and she was advised to continue ATT and steroid taper. Unfortunately, when she followed up at 4 months, there was this new lesion which could be seen temporal to the fovea, although the best corrected visual acuity was 20/40, and the patient was still on ATT, although she had stopped oral steroids. And the OCT showed this large bump again with subretinal fluid. And there was involvement of the outer retina as well. It was thickened and thrown into folds. And we again did an angiography where you can see this newer area of pinpoint leaks with pooling of the dye. So what was the cause of recurrence in this patient? Was it fast taper of steroids, or should we question the compliance of the patient, or alternative diagnosis such as non-infectious or immunological causes or Masquerade syndrome? So we advised the patient to get an oncology opinion along with a rheumatologist's opinion, and we also ordered ANA, RA factor, and serum ANCA for her. Unfortunately, she was lost to follow for nearly 2 months. And when she came back 2 months later, this was her 6-month follow-up, the new lesion that she had developed had completely regressed. Her visual acuity was 20/25. She'd had an oncology opinion in between. There was no evidence of orbital tumor or ocular tumor. The blood investigations that we had asked were all negative, and she was still on ATT. The B scan appeared normal, and so was the OCT. Because the take-home message here is that ocular tuberculosis can mimic any uveitic entity in part to the location of the infection, host response, and virulence of the organism. Posterior scleritis is many protein manifestation which warrants a high index of suspicion and a multidisciplinary approach, and causes of recurrence during treatment should be looked for and treated appropriately. Thank you.
Thank you, Ridhima, for nice case presentation. Now this case is open for discussion. Meanwhile, we welcome our President, Dr. Lalit Srivastava, sir. Dr. Lalit.
Well, I welcome to all Dr. Chakrabarty, Dr. Rajesh, and my senior professor, Dr. Visharia, my colleague, Dr. Chawla, Dr. Vivek Som, Dr. Mansi, Dr. Ashish, and Dr. Ridhima presented very nicely a very rare case, which we sometimes undiagnosed in such cases. So I'm extremely thankful to all of you for having this good webinar. Thank you.
Thank you, sir. Now this case is open for discussion. So please, panelists, go ahead with the discussion.
Dr. Ridhima, Chawla this side.
Yes, sir.
Very wonderful presentation and very nice case. Actually, I just want to share, I am also having a similar case which is under my treatment. The lesion what you have shown in follow-up after 4 months, that patient was presented with a similar lesion. I was treated with, and there was all test was negative. I thought of toxoplasmosis.
Okay. Okay.
Although the titer was negative, so in my clinical sense says that, then I started with the Bactrim DS, and she responded very well to the treatment along with the steroid. But again, with the follow-up, as you have seen that in new lesion, I have seen in other eye. So I was thinking whether when your new lesion came, I was thinking whether I was missing is that it is a presumed tuberculosis, or you are missing it is a presumed toxoplasmosis. So my this because in that case, patient is on Bactrim DS for say about almost 8 weeks now, and our second eye lesion is also disappeared. I don't know whether we are both are treating with steroid only, probably that is responding, or whether it is a really infective etiology.
So steroid I tapered very fast. I mean, we usually don't give steroid for a very long time. Maybe in 2 months, she must have stopped her oral steroids. She was on ATT when she developed the second lesion. And the case reports, that we've seen earlier, there are people who have responded only to ATT without any immunomodulatory therapy. So I was still wondering if we are dealing with something else, or whether we should give longer steroid or start other immunosuppressants along with steroid while we taper it off in such cases of recurrences. These are very rare.
Yeah. one point which I would like to say, like we usually see paradoxical worsening after once you give steroids, once you start the patient on ATT, and probably this tuberculoma which developed might be due to that, because the patient responded to ATT and the steroids which you continued, and the patient lost to follow up somehow, but the lesion did get resolved with time, and there was no other drug which was added. So probably that might be one of the reasons.
Paradoxical worsening we see immediately after starting ATT, not 4 months later. But she had already finished her intensive phase of ATT when she was on 5 drugs.
Yeah.
Already finished that, and she was on her continuation phase when she developed a new lesion. So I was not thinking in terms of paradoxical increase in inflammation.
Any access
Yes,
PCR
Dr.
was done, ma'am?
No, sir, no, we did not do. I planned to do, but unfortunately she was lost to follow up, and when she came back, everything had resolved. Then it did not make any sense to take an aqueous or a vitreous sample. We have tried that in the past. When we initially started labeling everything as presumed ocular tuberculosis, we did try taking aqueous aspirates, not vitreous biopsy, but aqueous aspirates, but it didn't yield anything. I have 12 of such cases where even when there was, I have 2 patients who had systemic tuberculosis when they presented with uveitis, but even then the aqueous aspirate did not show any MTV-DNA. So we do not know how helpful it is.
Quite dicey many a times. I mean, you won't get it positive.
Yeah. Yields are very low.
Yeah.
Dr. Devdulal?
Yeah.
I think I'm not the right person to comment because I don't, really do much of uveitis. So I'm basically a retina kind of a guy. So I really interesting. But what I thought was I would, maybe go with Dr. Ridhima that, probably this is a patient who needed steroids for a little more time, maybe. So, and, the other important thing is, like you mentioned, like post-intensive phase, there's a kind of a recurrence or worsening. So then probably one thing I would like to think is whether after the post-intensive phase, the two drugs, maybe rifampicin and INH, whether these are good enough for that particular patient, or the patient needs maybe a third drug. So that is something really dicey. And like you mentioned, I agree with you that we get from AC taps and vitreous taps is not what we clinically think. So, but excellent presentation. I really enjoyed.
Thank you so much, sir.
Dr. Som and Dr. Ashish, their comments, please.
It was a very nice presentation and a very sort of a rare case. And I would be tempted to label it as a paradoxical worsening, but then Dr. Ridhima is right that it occurred after 4 months. So maybe we can just maybe we cannot diagnose what the reason is, but the end result was that it got resolved. So all's well that ends well. That's fine.
Dr. Som?
In this case, in such cases, like there was no typical granulomatous reaction or choroiditis reaction. So it may have been because of other causes like, sarcoidosis and idiopathic also. So steroids obviously is the main line in this. Tuberculosis, it's very difficult to diagnose. And second thing, in such cases, it's obviously not a invasion by the bacteria. It's usually an immune complex mediated kind of reaction, even if it is scleritis. The sclera wouldn't be invaded by the bacteria. It's not common. It's not reported very commonly. So the steroid, obviously, you have to presume that it is either tuberculosis or sarcoidosis or maybe toxoplasmosis. And you have to, along with your antibiotics or ATT, you have to give steroids for a longer period of time. In the more typical kind of tubercular involvement of the eye or the posterior segment, you see much more clearer granulomas or patches of choroiditis rather than diffuse scleritis kind of picture. But then maybe in such a case, I would have followed the same line of treatment with probably a longer duration steroids.
Just one question here, one point of discussion. When we should start ATT in such situation? Was it too early to start in this particular case, or there is some guideline to start ATT when you presume ocular tuberculosis?
When you can't make any diagnosis, obviously that then only you're making a presumptive, treatment. It's one of the ways to diagnose tuberculosis in a country like ours is to, give a therapeutic dose and watch for the response. If it responds, then you presume that it is tuberculosis. It is not the other way around that you have diagnosed it as a tuberculosis and you are treating. You're treating and watching for the response. If you get a response, then you presume, because you don't want to err on the other side that you give steroids and not give ATT, and if it lines up with some other kind of disseminated tuberculosis or something. This is the normal thinking.
But the question of resistant TB is again we have to keep in mind.
Yeah, definitely.
Thank you so much. With this, we move on to second case, which will be presented by Dr. Paresh Nichlani.
Is the slide visible?
Yes, Paresh, move ahead.
Thank you. I would like to, on the outset, I would like to thank BDOS for giving me this opportunity to present a case on this platform. No financial interest. So I'm presenting a case of 35-year-old female homeopathic doctor by profession who came with complaint of pain, redness, and diminution of vision in right eye since past 1 month. She had a very elaborate past history. She had a history of 2 similar episodes in past which were managed at other centers. First episode was 9 months back, and she was diagnosed right eye cystoid macular edema with disc edema and posterior uveitis. She was started on Mypred 1 gram IV, slow IV, for 3 days, followed by tapering dose of omnacortil and topical steroid. Patient complaints were resolved in 2 months. These were the pre-treatment images. A rheumatologist opinion was also sought, which turned out to be normal. Investigation CPC, ESR, Montox, TBPC Gold, HLA-B27, they all came out to be normal. Again, after 3 months, she had a second episode. On examination, she had snow banking and slow bone mentioned in the inferior quadrant. Vision for right eye was reduced to 624 and left eye was 66. She was diagnosed as right eye vitritis, optic disc edema with CME. She was made started on oral and topical steroid and was advised to get a posterior subtenon. Patient refused, but she got one later. These were the images which I could get from her files. So more investigation was done, and they all turn out to be normal. ESR was raised, that's it, and everything else was normal. She had no systemic and significant family history of similar disease or systemic disease in past. On examination, right eye best corrected visual acuity was 6/18, IOP was 12, adnexa normal, conjunctiva had mild congestion, cornea had few pigmented KPs on the endothelium, anterior chamber was white, lens was developed posterior subcapsular cataract initial. She had grade 2 vitritis with snowball in the inferior quadrant. Left eye was completely normal. On fundus examination, mild hyperemic disc vessels were normal. Macula was also, it seemed elevated, and periphery showed snow banking in the inferior quadrant. Left eye on fundus examination was normal. So on OCT, she had a significant cystoid macular edema in the right eye. Left eye was completely normal. So on angiography, disc had hyperfluorescence with macular fern pattern radial hyperfluorescence, and left eye posterior pole was also normal on angiography. In the periphery, there was hyperfluorescence adjacent to the vessels in both the eyes, but it was more in the right eye, but also in the left eye it was present. So diagnosis of both eye intermediate uveitis with vasculitis secondary to most common tuberculosis or sarcoidosis or toxocariasis was made. More investigation were done. Montox was repeated again, stool examination, CT chest, VDRL, they all turn out to be negative. So the planned management was, we will give her a posterior subtenon injection with oral prednisolone 1 mg per kg body weight tapering over 10 days. 6 months of anti-COX treatment, topical steroid with regular IOP monitoring and central foveal thickness monitoring. And if she wouldn't have been resolved in 1 month, we would suggest her for total vitrectomy. So patient was started on topical steroid, but she refused for posterior subtenon because she had a raised IOP and orbital pain for 15 days in her previous injection, and she was also not willing to start on oral steroid. Patient eventually was lost to follow-up, and she went to higher center where she was advised pars plana vitrectomy. There also patient refused for the vitrectomy or any interventional procedure. Later, an intravitreal methotrexate was given with oral methotrexate 7.5 milligram once weekly along with oral steroid. But patient hasn't shown any improvement so far. One article we found very interesting shows the use of Ozurdex in these non-responding cases, which has shown a promising result. The points to ponder would be FFA can highlight even mild inflammation. Till this time, she was being treated only for the right eye, but on FFA, we picked up the vasculitis in the inferior quadrant for the left eye as well. So it was a bilateral case. Posterior subtenon with topical steroid works really well. Systemic steroid can be added later, and Ozurdex can be tried in the patient who are not responding to the case, these cases. The question to the panelists is the vitreous tab useful for TB-PCR? But the question has been already answered in the previous discussion. Any experience with Ozurdex in similar cases? Any further investigation because the patient is yet not relieved from his symptoms? Any change to be made in the treatment protocol? And any role or any experience of the panelists with use of intravitreal methotrexate in such cases? Thank you for your patient listening.
Thank you, Doctor, for presenting such a good case, which is nearly similar to Dr. Ridhima's case. So now the case is open for discussion. Panelists, please. Dr. Santosh.
Yeah. Dr. Paresh, how old is the patient?
So she's 34-year-old female.
I mean, whatever, I mean, as Dr. Devilal was telling, even we practice more of retina in my center. But we usually tend to see these EVA cases also, especially young patients and what you call non-resolving inflammations. Even I need to even consider neurological issues also. So sometimes MS and demyelinating disorders also can be an association. So especially this intermediate uveitis and pan uveitis kind of a picture. So I would suggest maybe you can subject the patient to that can be presenting. These can be presenting symptoms. And as I said, TB, sarcoidosis, these are the regular things of what we are really looking to. So maybe I can see from the other panelists what they think about your case.
Yes, sir.
Dr. Som. Any other panelists? Dr. Som, Dr. Chawla?
Sorry, you're muted.
Yes, sir. It's a very common condition that we see very frequently. Such cases come to the OPD, and usually it's very difficult to diagnose by routine investigations. Sometimes you might get some changes on the X-ray, but usually other investigations are, you don't yield anything. And what we have seen is they respond very nicely to immunosuppressants or immunomodulated drugs like methotrexate. And they have to be kept on them for a long time with sometimes you have to add the steroids as a rescue therapy whenever, in spite of the immunomodulators, they flare up, then you can add steroids to treat them intermittently. And most of the time I've seen that they respond very nicely to combination of steroids and immunomodulators. And only sometimes you might need to add Ozurdex or maybe other drugs. A combination of steroids, if not being tolerated, posterior subtenons and immunomodulators, a combination of both of them also treat them well. But as far as making a diagnosis in these cases, it's very difficult. You might as well try, if you want, like has been proposed by various other seniors, that you can take a vitreous tap or biopsy and send it for an RT-PCR for a definitive diagnosis. But what even they eventually say come around to the same thing, that you would have a very rare chance that you isolate an organism or have a positive RT-PCR. But that attempt to diagnosis can be made. but usually a combination of immunomodulators along with a subtenon or systemic steroid, depending on how well the patient tolerates the steroids.
If I can make a point, rather an observation. So number one, like Dr. Som just mentioned, it doesn't matter whether other people have had positive results with RT-PCR or not. It has to be done actually in such a situation, especially. The other issue is we see here a lot of VKH, and so like these are kind of incomplete VKH. But when you have a bilateral involvement, I think this is something that has to be there on the back of your mind, because these are cases also which, like Dr. Som mentioned, they resolve with nothing else but steroids and immunomodulators, or maybe some immunosuppressives. So basically it boils down to the fact is whether we are seeing a slightly different form of VKH here. So so I think just an observation. So sometimes
yeah, actually in the fluorescein angiography that he showed, they were quite late pictures, but you can actually, this is a very important point that you made. VKH would sequentially involve both, even if it is an isolated one, can involve both the eyes. Second thing is VKH is more characteristically having thickened choroid and multiple pinpoint leaks in the early phase of fluorescence as compared to the other MEWS or multiple evanescent white dot syndrome patients. So VKH has very characteristic ophthalmic features which can help you diagnose VKH. But that has this was not an apparent VKH as per the fluorescein angiography photo that picture that he showed.
Can't we give anti-tubercular in this patient also?
Ma'am, we advise, but she's a medical professional, and when you have a medical professional as a patient, it's very tedious to make them understand that this is the therapy you should go for. So she will.
No, I'm just asking, leave aside that medical professionals. If this is a case, do we prescribe ATT?
No,
Yes,
in this particular case, the all investigation were negative. So until unless you have something to support, like in Ridhima's case, at least MT and TB gold was positive. So that was a point where we can think of starting. But in this situation, and that too in first and second attack, I presently reserve myself to start the ATT. So I think one has to convince, he says, okay, patient is not convinced for taking the subtenon. So as a doctor, you have to convince them it is the best treatment along with the systemic steroid and immunomodulator, as Dr. Vivek has already mentioned about. So that is in when there is intermediate uveitis, PST is the treatment of choice along with systemic. That respond very well.
Any experience there with like Som sir told that she's already on Vislon and methotrexate, and she's also got one shot of intravitreal methotrexate as well, but she's not responding to that also. So Som sir, do you have any experience with this intravitreal methotrexate therapy?
In this case, I don't think I'll like to go for intravitreal methotrexate. I don't know. I guess we can ask Ashish what is his experience in such cases.
Actually, in such cases like non-responding uveitis, I agree with Vivek that we can add immunosuppressive drugs, because I have few patients who are very well controlled on that, and my experience is more with azathioprine. So it works very well with oral steroids, and there is good long-term control with azathioprine. So,
sir, I have a similar kind of a patient like who had bilateral these kind of lesions, but he was not tolerating any immunomodulator either. Sometimes it's a real diagnostic dilemma. What thing is it? But I guess always rheumatologist opinion, rather any vasculitic, systemic vasculitis, other factors such as CNK, PNK should also be done, and those profiles should be ruled out. And Ozurdex do work well. Even I have injected PST and Ozurdex both, and they both work well.
One more point I would like to stress is, especially in elderly patients, is to consider a diagnosis of intraocular lymphoma also, because I had a similar patient who was not responding, but he had she was a lady around 60 plus, and she had some retinal lesions as well. So then I sent her to a higher center where a vitreous tap was taken and intravitreal rituximab was given. So that was followed by very good resolution of lesions. So,
Sir, any role of total vitrectomy, because it will take out the load of the vitreous? Any load role?
Actually, Paresh, I'll like to intervene. I'd like to add a point here that these are the cases where you may, when it is not responding and it's a high profile patient, as per it's a sensitive patient, then you can always advise a vitreous biopsy, which can be sent for evaluation, because it's much more easy to convince such patients that we go for a diagnostic procedure, which might prove to be a clinching thing. Second thing, these are the cases in which you might attempt to give a therapeutic kind of diagnosis. You give an ATT and watch for the response, and then maybe you might get tuberculosis might be there, and you are not ocular tuberculosis is there. So you can do a vitreous biopsy in this case and send for further diagnosis evaluation.
Sure, sir. Thank you, sir.
Sometimes we also do blood culture and urine culture and see if there is some, focus of infection somewhere else. I have had one patient of endogenous endophthalmitis, post valvular replacement surgery, who presented with, bilateral involvement. It looked like, vasculitis initially, but then when she gave the history of having valve replacement surgery, and then we did a blood culture, it came out to be positive for fungus. So it was basically a candida, infection. So maybe a blood culture or urine culture may add some valuable information.
Sure, ma'am.
Thank you. Thank you so much. Now with this, we move to third case presentation by Dr. Fazil Khurram. Dr. Fazil, please.
Okay. Good evening to all of you. I would like to thank BDOS for giving me opportunity to present my case. So I've got no financial interest. A 56-year-old patient presented to our outpatient department with complaint of diminution of vision in left eye from 8 months, which was incidence since onset and was gradually progressing. It was accompanied with the pain in left eye for last 15 days. Patient is a known diabetic and hypertensive for last 3.5 years on medication, and he also has a past history of ischemic CVA in 2020. Her best corrected visual acuity in left eye was 6/60. There was conjunctival congestion. AC was 100 grade 2, but there was no signs of any cells and flares. On iris, there was presence of new vascularization of the iris along the pupillary margin from 1 o'clock to 5 o'clock and 7 o'clock to 11 o'clock. There was also a presence of new vascularization at the base of the iris from 2 to 5 o'clock and 7 to 10 o'clock. These are the pictures showing the iris new vascularization at the pupillary margin, as well as the conjunctival congestion and at the base of the iris root also. His IOP with anti-glaucoma medication prescribed from outside was 18 and 20 mm of Hg with GAT, and he was on bromidine and timolol in both eyes. On gonioscopy, the right eye was open in all quadrant as well as open on indentation, when left eye was closed in all quadrants with the presence of NVAs in inferior and nasal quadrant. This is the right eye gonioscopy, and this is the left eye gonioscopy feature. On fundus examination, the right eye fundus was within normal limit with normal AV ratio, with no hemorrhages, and the disc was also normal with healthy NRR. While coming to the left eye, there was arterial attenuation with AV ratio of 1:3, and there was a significant bleeding in one of the arterial vessels coming from the disc. The OCT was normal in both the eyes with no presence of macular edema. On routine blood investigation, her fasting was both sugar parameters were raised with HbA1c of 9%. Serum triglyceride and serum cholesterol was also raised. This is the FFA with increased arm retinal circulation time as well as the arm AV time, as well as there was delayed choroidal circulation. Then on doing this, we referred it to a cardiologist to perform a carotid artery Doppler, which showed a left-sided block at the bifurcation of common carotid and internal carotid with 60% of the altered flow in the left artery. So a diagnosis of left eye ocular ischemic syndrome with NVE and NVA with nucleus sclerosis grade 1 cataract was made. So coming to the discussion part, ocular ischemic syndrome is ocular signs and symptoms are secondary to severe corneal arterial hypoperfusion secondary to carotid artery obstruction. Key features are visual loss, decreased ocular hyperperfusion, ocular neovascularization, and severe ipsilateral or bilateral carotid artery obstruction. But in our case, we did not find any dilated, beaded retinal veins or any blood retinal hemorrhages in the mid-periphery, which are documented in the literature. There could be an associated pain, corneal edema, mild anterior uveitis, cherry red spot, cotton wool spot, and ischemic optic neuropathy. On further studying the literature, we could find one study from Jaworski et al., which have described an anterior segment ischemia due to ocular ischemic syndrome, which has the features of conjunctival congestion, episcleral congestion, and ciliary body hypoperfusion and ischemia, which leads to an IOP drop instead of an increased IOP in spite of being a so aggressive NVG, which releases the formation of endothelium cells, formation of NVIs and anterior uveitis, and might cause raised IOP in later cases. The other thing they described was a posterior segment, that is the classical ocular ischemic syndrome with retinal arterial narrowing and venous dilatation, retinal hypoperfusion increase, which leads to microaneurysm, cotton wool spots, and hemorrhage in mid-peripheries, and which also leads to optic disc hypoperfusion and AIOI. So the treatment option we had was to first to counsel the patient about the visual prognosis, and anti-VEGF can be tried in this case patients to reduce the NVG and NVIs. Pan-retinal photocoagulation is also a preferred treatment where retinal hypoxia and fluorescence angiography shows an evidence of retinal ischemia in the form of retinal capillary obliteration. Thank you.
Thank you, Dr. Fazil. Now the case is open for discussion.
One of my question to the panelists is, I have got 2 to 3 cases of similar picture ocular ischemic whose vision is 660 or 636. So any of the panelists have an experience with such type of cases which does not have a vision such as hand movement close to face with ocular ischemic syndrome documented on carotid Doppler?
By the time I believe the vision goes to hand movements and all, it would have been advanced NVG. So that's the issue. So, but since it's detected early, that could be the ischemia could be the cause of the decrease in vision and the inflammation that goes on. But once NVA starts, sometimes there's no looking back. We need to be very aggressive, like how you went about intravitreal injections and lasers. So that's how we need to treat, because most of the times they present late in the disease and we won't even know what's happening and what would have been the cause for these until unless again you do a Doppler. And again, if you look at sugars also, they are a misleading factor, though it's an ethical presentation of DR, but it is a misleading factor when you look at the HbA1c of 9 and above.
What was the blockage in the carotid? How much percentage was there in the block?
60%.
So usually they say if it is more than 90 or above, then it creates a lot of ischemia. 70% is okay. Like I am aware of. The panelist can correct me.
Sometimes even 90% usually they do remain asymptomatic, ma'am.
Yes, that is what they say. If it is more than 90%, then it is significant. If it is 60%, I think it's okay. Probably we can think of diabetic retinopathy or something like that.
No, but the diabetic retinopathy, the clinical picture doesn't support that diagnosis. It has to be ischemia, and if there is a NVE, NVG, so probably there is definitely hypoxia and ischemia. So one has to be look up for something else.
Yes, there is no hemorrhages.
Yeah, there was few. There were.
Even in fact,
there were few.
In other eye also.
No, there were few, not like going for a straight
Typical
going
PDR
for.
patient.
Yes,
Typical.
yes.
When you look at arm retina time, I mean, that itself kind of gives you a clue that you need to look for something else. Maybe, I mean, as you did the Doppler and all.
What was the lipid profile and the cardiological checkup of the patient?
The lipid profile were deranged. Serum triglyceride cholesterol level were high. So the cardiologist at our institute advised correction of the lipid profile and then repeat the carotid Doppler and might do a angiograph to remove the block later.
Dr. Ashish, Dr. Som, any comments?
Yeah, it's not a very unfrequent kind of situation. Like in many of these cases, it's a dilemma, you know. But in your case, you definitely have a carotid, artery stenosis. There is no doubt about it, and the amount can, I'm not sure if it is 80%, 70% or more, but it's in such cases which are hypertensive, which are diabetic, compromised carotid. They on maybe antihypertensives, they can have a reduced perfusion in the eye because of a combination of factors. So the ischemia and the changes of neovascularization are definitely suggestive of ischemia. So you have to make a coordinated effort with the cardiologist or the physician to basically keep the patient on a kind of medication that such ischemia is relieved medically. Part of the perfusion can be improved. The second thing you have to rule out is even if you give anti-VEGF in these cases, it is only going to last for maybe, it's not going to treat the condition. It can reduce the neovascularization for a month and then it is going to come back. So it is not a definitive solution. Yes, anti-VEGF in the left eye, since the IOP is raised and the vision is good, you can give an anti-VEGF and then maybe plan maybe, trab with MMC or a valve implant. Yeah, that you can try, along with your glaucoma specialist, you can plan one of these procedures so that you can control the IOP. But the question again is going to remain the same. On the long term, the valve and the trab are going to fail because the ischemia is going to persist. So the only option you have is make a good friendship with your cardiologist and try to improve the perfusion of the eye and find and treat accordingly, because your angiogram did not show too many capillary non-perfusion areas. So we all are aware that diabetes itself is going to compromise. Second, hypertension. Third, hyperlipidemia. Fourth, carotid artery stenosis, multifactorial problem. The only way you can help the patient is to give a good glycemic and hypertensive control and use medications in which there is no nocturnal dip in the IOP. That is also going to reduce the ischemia in the retina. And maybe use anti-glaucoma drugs like dorzolamide and other, which improves the perfusion of the nerve.
I guess one thing also what we can plan is, apart from carotids, MR angiography for other vessels, like going right up to the ophthalmic artery, whether there's stenosis in anywhere else also, because such patients may have multiple areas of ischemia.
I think you brought up a very important point, and that is something that often we see that these are patients who actually have a compromised optic nerve perfusion per se, like the vasa nervorum also are kind of stenosed, which is something very difficult to prove. But we get some indirect evidence in the form of VEPs and stuff like that, and we see that the nerves are not functioning properly. And like you mentioned, I also have some similar experience that almost all of my patients coming in with ocular ischemic syndrome like features, they present kind of late. So this is something that's really worrying. And they are not really aware of this 636 vision that you spoke of. So that is something, it's a kind of a global ischemia that Dr. Som was mentioning, like, there are other things going around in these kind of patients. And, so they need, a lot of investigations maybe. And obviously, they need to be put on, drugs that can help improve their perfusion. So this is something that's very important. And don't be shy of doing lasers, because like I agree entirely with Dr. Som that the anti-VEGF is for a short period. It's just to tide over the kind of corneal edema if it's there, or the NVI, for a very small period, but they do work very well. And in this 2 to 3 weeks following the anti-VEGF, you need to go blast the retina and go up to the periphery in these cases, because it's the periphery that's more that needs laser, as opposed to our previous teaching that you can go up to the equator in diabetic retinopathy. I this is something that I don't believe personally. I really like to go up to the aura even in diabetic retinopathy. And this is one situation where you actually need to go up to the aura. You will find some of these patients coming in with small pupils post surgery or otherwise, or maybe a phakic also, elderly people. So in such a situation, do laser to whatever extent is possible, and even maybe use anterior retinal cryopexy to be doubly sure that you have additional coverage of the periphery, sort of, to kind of, because this is a very difficult kind of a situation. They don't do well. That's the bottom line. Like Dr. Som mentioned, these kind of everything fails in these situations. So you need to go full blast from the right, from the first instant. I mean, first time.
And the logic for doing laser in these cases is unlike diabetes and other conditions in which you are trying to treat the capillary non-perfusion areas. Here, by doing lasers to the anterior part, you are actually reducing the amount of oxygen that is demand of the eye. So by doing that, you prevent some amount of the VEGF that is being secreted, and try to preserve the eye for a longer period of time. It's very true. Doing lasers always helps in such cases.
Definitely, after doing the lasers, probably the glaucoma also subsides. So you may not
and
need
lasers
any
are not
anti-glaucoma surgery.
Yeah, exactly. And the lasers in these cases need not be, those typical lasers in which you leave those areas. You can do a very tight, we call it tight PRP, extending to the extreme, like to the aura, as was told.
I would just like to add a point to Madam's point that the stenosis is a bit relatively less, like 60%. But there is, I think, evidence of ischemia because the NVI is actually out of proportion to the fundus picture. And as Vivek said, there's not much capillary non-perfusion. So NVI is a very significant feature of ocular ischemic syndrome. And there are other combination of factors such as hypertension and diabetes also. So I think it's good to refer the patient to a cardiologist, because if it is ocular ischemic syndrome, then the mortality also increases for the patient if in presence of ocular ischemic syndrome and carotid artery stenosis. So it's good that he has been referred to a cardiologist to diagnose carotid stenosis.
So it's more of an anterior segment ischemia rather than posterior.
Right.
Posterior segment.
So let's move on to presentation by Dr. Santosh Gopikrishna. He will be presenting brolucizumab, my initial experience. Dr. Santosh, please, you can carry on with your talk.
Slide is seen, Amma.
Yeah.
Thank you so much. Good evening, all. And at the onset, I'd like to thank BDOS for this opportunity. So I'll be talking about a few cases of Broly which I've used in AMD and PCV. So these are a few accumulation of cases which I presented earlier also, and added a few more. So this is a disclaimer, no financial interest here. So coming to the case one, it's a case of double layer sign, what you can see here, and subretinal fluid, and typically treated with anti-VEGF, especially Eylea in this case. And there's a great resorption of fluid over a period of time, but patient was lost for follow-up in December due to COVID. The fluid had come back this time, but this time there was a little suboptimal response. The fluid really didn't go down much. But again, she was lost for follow-up 3 months later. The SRF this time had increased, and this time it was more resistant to the same treatment. So it was not really very responding much to Eylea. So this was a follow-up after 10 days, and then this was the time wherein I had given Broly. So there was a great response to Broly, and after second brolucizumab, the subretinal fluid kind of went off, and it's been quite some time that the fluid didn't come back. So this is a case of when there's a loss of follow-up, and we had a recurring SRF with suboptimal response in BVN and PCV kind of scenario where we injected a Broly. This is again a second case, the solid PED and SRF, and you can see the STEM here. So Octa shows CNVM complex and the BVN. The fluid kind of started going down after anti-VEGF injections, but this time there was in this case, there was suboptimal response. The fluid really didn't flatten further much. So the SRF was persisting even after 3 doses of anti-VEGF injection. So loading dose, and this was the time when Broly was injected, and due to its mostly greater sub-RP penetration properties, you can see the RP flattening and solidifying more further, and there was an instant response of SRF also that came down. And first and second Broly, and after second Broly, it was stable after that. And this was the time we kind of followed up for a period of time, but didn't need to inject the patient again. It's another case, a case which was treated earlier for a long time, even before I started seeing him in some 2019, 17. So it was in 17 actually. So it was a case of PCV, and I went to PDT at a center in Hyderabad. And then this was a solid PED. You can see intraretinal fluid and hard exudate, which denotes chronicity. And you can see a BVN here and polyps also. So this was a time wherein I kind of gave injections. So, but the patient really didn't respond much. The vision kind of was maintained because the fluid at the posterior pole, especially the fovea, was flat. And there was a good response to PDT at some point of time where I did a PDT, but the solid PED kind of persisted, but the IRF kind of went down, even the exudation kind of decreased. The patient, again, due to COVID, was loss of follow-up. This was, you can see the BVN and polyps here. This was recently in 2020, 21, and this was, vision had come down because of this HRM exactly at the fovea, and you can see the IRF and the solid PED that remained as it is. The patient was non-affording initially to start with, wherein I given a regular anti-VEGF, but the hyperreflective material persisted. So this was again post-Broly. You can see the hyperreflective material also went off at the fovea. It kind of decreased. It kind of started solidifying, and intraretinal fluid, which was persisting for a long time, that also started coming down. So this is a case of acute and chronic PCV and intraretinal fluid. So and with a solid PED, which kind of resolved very well after a single dose of Broly. So recently I had injected a second dose. The patient decided to come for the follow-up. This is a case of one-eyed patient presented at multiple forums. So the other eye was lost for scarred CNVM. This was a tense PED, and you can see the polyp here with BVN on ICG. So the patient was non-affording initially, so Avastin was given to start with bevacizumab, and there was, though the SRF went down, the hard exudates persisted. PED was not very flattening, and I changed it to aflibercept. There was a good response initially. The PED started flattening further, but again it kind of started increasing, and in the month of Feb the PED had increased. So this was a time where you can't go ahead with the same injection, nor can you do some laser to that because of the risk of rip. And started injecting brolucizumab, and the PED started flattening. And after 3-4 bolus, you can see a completely flat PED here. And it's been 4 months. I saw him just 2 weeks back. So this was the latest scan wherein the PED is completely flat, and it's been 4 months that I haven't really injected. So he's doing good. I mean, it's quite a gratifying thing wherein you see one-eyed patient with glaucoma and tense PED that's kind of flattened and remained as it is even after 4 months. And this is a straightforward case of again a double layer scan and intraretinal fluid. So nowadays, since lack of PDT, we don't even do ICG because only Octa most of the times we know that we can't do PDT. So this is the time we usually treatment naive patient, and I started giving Broly. After first injection, you can see the PED starts kind of flattening a little bit, which is already shallow. IRF started going down, and this is after first injection, then again second injection. So this is how the response was after first and second injections. So the PED kind of flattened, and intraretinal fluid, which denotes some kind of chronicity, that also came down readily with 2 injections of Broly. So this is a comparison of cases between one case which already had an RP rip and quite some amount of exudation and HRM. And so ultimately, these kind of cases, we all know that they start with a good vision, but once we start injecting because of the remodeling, the vision kind of goes down. So this was a bad PE to start with. You can see the sub RP hyperreflective material also. But after one injection of a regular anti-VEGF, there was a rip, though the vision kind of remained 612. So then again, after multiple injections, though the PED kind of started solidifying, you can see the SRF that came back. So this was the time we changed to Broly in both eyes. So there was some amount of fluid in the left eye also, for which Broly was injected, and even for the right eye. So you can see after 1 or 2 injections, the PED kind of was white, and you can see the SRF also went down, but the hyperreflective material at the foveal region was a cause for 636 vision. So this kind of remained stable after multiple injections, and again the SRF started coming. They're difficult cases to treat with, and a patient, though, as you know, starts with a good vision, goes down because of the remodeling. And so the difference here is Broly, the way it can, by the way which it can kind of dry the subretinal fluid, and it can kind of make the PED a little more silent for quite a long time. So this is another case which I had been following it for many years. So this was, they came for second, third opinions. There was subtle amount of SRF and subjected to multiple injections, including Avastin, ranibizumab, and more than 30 injections were given. So Pachy vessels were there, and if you look at FFI ICG, it really doesn't show anything other than this Pachy vessels here and some amount of window defect and kind of staining over late phases. So multiple injections later, multiple switchovers from all the injections, it kind of never responded. There was a highlight that was attached. Maybe I thought maybe this was not kind of allowing it to settle down. Though it was relieved, then it kind of came down. You can see the outer retinal, the photoreceptor outer segments also accumulating here. The PD, which remained the same. So 2020, but again in 2021, if you look at it, the activity was the same. There was no polyps or especially BVN kind of a situation. The patient had nystagmus for her, which I couldn't get an opta. And in Feb, you can see the fluid started increasing. And in June again, this started kind of spreading downward. You can see the increase in fluid, which has kind of started going down. So this was the time I switched over to Eylea. But there was initially a good response. Maybe the fluid kind of started decreasing inferiorly, but again, it started accumulating posteriorly, especially at the macula. But again, in December, you can see the SRF kind of increased. So again, I was lost for choice because the vision also slowly started coming down after these many years. The vision now was 624. So after one injection of Broly, you can see a great response of the fluid going down. The PED has been there same for a long time. Pachy vessels, you can see. So now it's been 20 days. I saw the patient just 2 days back. So it's a chronic persisting SRF, even after multiple anti-VEGFs, you can see a great response Broly. The final case here, the case of bilateral CNVM, again, these kind of PEDs with sub-RP hyperreflective material. Though the fluid kind of responded very well in the right eye, there was a recurrence. And left eye, I've been treating with Eylea. And you can see in the right eye, it was a little persisting and recurring course to start with. And because of these solid PEDs and intraretinal fluid and intraretinal hyperreflective material, though I mean, even after regular anti-VEGF, but there was a poor follow-up due to age after some time. So you can see the SRF and even the IRF kind of persisting, and the hyperreflective materials are increasing. The vision was not great throughout. It was from 636, 660, but the persisting IRF was a concern. So I had given Broly in this point of time. You can see a minimal decrease in IRF here, though the solid PEDs didn't respond much. So this is post a second Broly. You can see the IRF still persisting. Maybe a combination therapy with an what you call a steroid might help in such case. So I'm still observing this case. So this is a recalcitrant and tough case of solid PEDs with intraretinal hyperreflective material and IRS. So my experiences, apart from this, there are other cases wherein my experiences mostly have been in chronic CNVMs with fresh recurring activity and the tough tense PEDs, especially in one-eye situations, persisting SRFs and HRMs and flat ends with PEDs with recurrence. And we even tried in treatment naive cases with great response, and even one-eye patients with recurrence. So it's been a great response when there's no response to other anti-VEGFs in such cases, most probably because of the greater sub-RPE penetration. And so far, I haven't had any intraocular inflammation. So thank you so much for your patient listening.
Thank you. Thank you, Dr. Santosh, for the excellent cases you have shown. It gives a great response with brolucizumab. We have all seen that that PD just flatten up with the brolucizumab. What I asked to Dr. Chakravarti also, does it make your first drug of choice for your treatment in cases with PCV?
There are certain cases which I would consider it as a first line of choice. Certain cases, especially like, though ILIA is around, there are cases wherein it's a chronic case and lots of intraretinal fluid and even flat PEDs and solid PEDs. These are the ones I would maybe kind of consider it as a first line of thing. Otherwise, mostly it has been a drug of choice as a rescue drug for me in all these cases.
And you use loading doses or PRN basis as Dr. Chakravarti is using?
Yeah, it's PRN now. Even here, we don't use as a loading dose because we've seen that the effects really last for easily 2.5 months. So there's no point. But the follow-up is essential. Initially, when we started observing at 1 week time, then again 2 weeks, then 1 month later. But now 1 week later, and then again I start following them up with 4 weeks interval.
Even Novartis has now given that 12 weeks is the minimum interval.
Yeah.
Now it's open for discussion to the panelists. Dr. Chawla, is this a drug of choice for you?
Yeah, actually, I have used not many, but few of cases I have used, but not as a primary treatment for the treatment now. But yes, in recurrence and recalcitrant cases, we definitely have given and showing a very good response. Even as Dr. Chakravarti in his talk has mentioned, it is a chronic disease. We have to give anti-VEGF throughout the life. Definitely the time interval what we are getting with this, because 3 of my patients recently I have seen, which I have given injection and I have re-injected after 3 to 4 months in all of them. So with other drugs, probably we have to inject every month or 6 weeks. And now I am little more confident of asking patient to follow even after say 2 months, not every month. So that way, probably we are having a longer duration of action with this particular drug. So definitely it is having a good response, and we are having a less visit of the patient to the hospital and a less OCT and less number of injections. I don't know, because when ILIA was introduced, they says it is effective for 8 weeks, but nowadays again they says every month you have to inject. I don't know what the future with this drug will come, but the initial experience will say yes, it is effective for 3 months.
Dr. Som?
Yeah, I'd like to congratulate Dr. Santosh for a very nice presentation. And there's very interesting thing that I noted in your presentation, that most of your cases are type 1 CNVMs and associated with pachychoroid vessels. So from your study, I can take home a message that, maybe in such cases, you can use it as a first choice drug.
True.
Definitely it is.
Yeah, from your presentation, I can take home the message that if it is a type 1 CNVM and has associated pachychoroid features, you can definitely use a brolucizumab as a first choice drug. And if we there's some residents, if previously when we used to do angiography to diagnose CNVMs and their types, then all these cases would fall into occult CNVM type of cases. So these cases, definitely any kind of treatment, previously also if you used to do lasers or anti-VEGFs, they are very recalcitrant to treatment. And definitely these, if you find any of these features, rather than loading them with anti-VEGFs, we can start them with maybe, Pagenex or something like that.
Dr. Ashish?
Yeah, very nice presentations by Dr. Santosh and Dr. Chakravarti. So going by their volumes, now I think I'll have more confidence in prescribing brolucizumab, because the inflammation concerns were always there, especially reading the Western literature. But as Dr. Chakravarti said, maybe Indian population is less prone to inflammation secondary to brolucizumab. So maybe I'll now prescribe more of that. And the results, as seen from the presentations, they are very good. So that's the take-home message for me.
Dr. Javir?
Yeah, ma'am, even in many of my cases, I've seen a beautiful response with this drug. There's no second take on that, but I usually reserve it for recalcitrant cases.
Dr. Ridhima? Is it your
Yeah,
first
even
drug?
no, it is not actually my go-to drug. Again, safety concerns are, one of the issues. But again, I think watching such loads of, experience from such experienced retina specialists, I think, like Dr. Ashish said, we'll have more confidence in using it more. I actually have had a couple of cases of inflammation, so I am a little, it is my reserve drug.
Yeah, definitely it seems to be more promising, but we have to keep a watch on vasculitis. With this note, we will move ahead to our case presentation again by BDOS members. And in that series, now the case will be presented by Dr. Dhirendra Singh from ASG, followed by Dr. Nazia Sheikh from GMC. So first, Dr. Dhirendra, please share your screen.
Yes, ma'am. Are my slides visible, ma'am?
Yes, you can make it slide share and proceed.
Good evening, everyone. First of all, I thank the BDOS for giving me an opportunity to present this case. I have no financial interest. A 21-year-old male presented to our clinic with the complaints of sudden onset unilateral painless diminution of vision in his left eye over 3 days. And he had no history of trauma, colored halos, scotomas, metamorphopsias, history of drug abuse, headache, flashes, floaters, vomiting, or any such similar history in the past or any of his family members. So upon examination, actually the right eye had an unaided visual acuity of 6/6 and the left eye affected eye was 636. However, the pupillary reaction, both direct and consensual reactions were present, with the intraocular pressure noted 17 and 18 millimeters of mercury in the right and left eye respectively. Even the anterior segment examination was normal, except for the fact that retrolental cells were present in the left eye. And this was the fundus picture noted. So in the right eye, we have a cupping of 0.5 to 0.6 and dated 30th of July 2018. Actually, we have a track of this patient that I'll be sharing. There's a hyperemia of the disc with multiple hard exudates and macular edema with subretinal exudations and multiple mid-peripheral aneurysmal dilatations that were noted. Even on the angiography, we noted a hot disc and again multiple capillary non-perfusion areas in the left eye with leakages that were noticed. And again, on the OCT, a frank subretinal fluid, a macular edema with hyperreflective dots suggestive of hard exudates. And we initially started with oral as well as topical steroids, and a sectoral laser was advised. And we do all the investigations, a complete hemogram, ESR, MON2, C-reactive protein, even serum ACE test, and Lyme titers, and even HIV ELISA tests were given, but all of them were negative. Still, after a follow-up with all the investigations, when he came after a follow-up of 7 days, the visual acuity improved to 6/9 parts, and however, the intraocular pressure raised to 34 in the right eye and 32 in the left eye. So most probably the patient was actually a steroid responder. So we started the patient on anti-glaucoma medication, timolol brimonidine with brodalumide in both the eyes. So again, after 2 months, on 14th of September 2018, again the patient came with sudden onset diminution of vision in the left eye with visual acuity of 3/60, And I apologize, I don't have the fundus picture at present. The left eye fundus had a lot of exudation with subretinal fluid temporal to the fovea. This was the OCT of the same. And hence again, we gave intravenous methyl prednisolone pulse therapy along with the PST in the left eye with again topical steroids under anti-glaucoma cover. Then a month later, the visual acuity again improved to 6-9 parts, but an IOP spike of 44 millimeters of mercury, but the patient had a poor compliance with the medication. And again, a month later, the visual acuity recorded was in the left eye 6/6 parts unaided with the intraocular pressure of 23 millimeters of mercury under anti-glaucoma cover, and the right eye was 6/6. Then the next follow-up dated 20th of December 18. The left eye again visual acuity dropped to 6/36. Presence of multiple exudates at the level of the macula, and hence we did laser augmentation again with a PST injection in the left eye. So now then, after over a year, almost a year, he remained quite asymptomatic. The visual acuity unaided improved to 6/12 partials and the best corrected to 6/6 parts. The intraocular pressure was maintained 14 and 13. Again, after a month, the best corrected visual acuity 6/6 parts, and in the November also, the vision actually improved to 6/6 with the normal intraocular pressures in both the eyes. But to our surprise, again, 6 months later, again, the patient came with a visual acuity in the right eye of 3/60, slit lamp examination again showing retrolental cells, and the fundus examination revealing a breakthrough vitreous hemorrhage. Then, but the patient was managed medically, advised a proper position with oral and topical steroids again under anti-glaucoma cover. So after around 12 to 13 days, the visual acuity again improved to 6/9 parts and best corrected to 6/6. And the intraocular pressure of 22 and 24 millimeters of mercury in right and left eye respectively. And after that, after clearance of the vitreous hemorrhage, laser augmentation of the CNP areas was done. So then again on 23rd of July, the visual acuity noted was 6/9 parts and the best corrected visual acuity of 6/6 with normal intraocular pressures. The hard exudates actually cleared off the macula, and we can see the laser marks as well. So just a brief information, retinal vasculitis, it's a slight threatening condition, can be isolated or occur as a complication associated with inflammations, infections, or neoplastic disorders, first given by John Hunter in 1784, and can be phlebitis as well as arteriolitis. And as far as epidemiology goes, the annual incidence is 1 to 2 persons per 10,000, and it is more common under the age of 40 with more female preponderance, and it is usually a bilateral condition and may present with a visual acuity of 6/60 or even less, and typically can occur individually or a part of systemic disease. And if it is occurring individually, it can be known as idiopathic retinal vasculitis. And isolated retinal vasculitis can be seen in approximately 3% of cases diagnosed with uveitis. Again, the stages, the stage of active inflammation, the perivascular sheathing, hemorrhages, retinal edema, macular edema, stage of ischemia, stage of neovascularization, and lastly, stage of complications, meaning the vitreous hemorrhages, rubeosis iridis, neovascular glaucomas, or even retinal detachments. The Irvan syndrome, however, is an idiopathic retinal vasculitis, arterial microaneurysms, and neuroretinitis first contributed by sardonyl gas. And it usually affects younger patients with, again, a female preponderance, and it is usually a bilateral condition not associated with any systemic diseases. So again, the criteria were given by Samuel et al., the major being retinal vasculitis, neuroretinitis, aneurysmal dilatations, minor being capillary non-perfusion areas, neovascularization, and macular exudation. All these categories were actually fitting to the patient that I just presented. Again, a revised classification extending the presence of exudation to two parts, 2A being extrafoveal and 2B being foveal exudation, and also including retinal detachments. Just a review of literature. Chang et al. First described a bilateral condition affecting females, and however, atypical cases were reported, like Gedek et al. Reported in 2005 a unilateral Irvan case in a female. Norlina again reported Irvan unilateral case and unresponsiveness to the immunosuppressants that can be able to differentiate from systemic vasculitis. Again, Darrell et al. Also demonstrated a bilateral Irvan in a male was fitting all the criteria. Again, an atypical case, and Norina et al. Again reported Irvan syndrome with systemic association with positive P-ANCA antibodies. So the take-home message is Irvan is a rare idiopathic disease of unknown etiology having a urinatal presentation, and it is actually a diagnosis of exclusion. Hence, all the other etiologies have to be excluded. Early PRP can be done to of the CMP areas to prevent new vascularizations and further complications. However, response to oral and topical steroids can be temporary. And treatment protocols include PRP, cryotherapies, vitrectomies, peri or intraocular steroids, and however, it can severely affect the vision if not managed properly. But yes, now to a surprise, actually, the last noted as a showed that the best corrected visual acuity was 6/6 in the left eye. But hence again on December 21, this patient again came with the vision of counting finger 1 feet in the left eye, and there was a mild PSC with vitritis, subretinal exudation with hard exudates at the macula, aneurysmal dilatations, and we had to again put him on oral and topical steroids. A week later or 10 days later, again the treatment continued, but there is no improvement, and there is development of vitreoretinal traction membranes, and again the OCT of the same. And this is the final follow-up. On 16th, he came again with development of a hot disc and vitreoretinal traction membrane, subretinal exudation, and the vision is still counting finger 1 feet, though he is on topical and oral steroids. And also, we also gave a PST on that day. So actually now, how do we manage? We've actually advised the patient for anti-neutrophil cytoplasmic antibodies, HLA typing as well, meaning serum autoantibodies. And how do we proceed? We are actually planning for a cryotherapy of the peripheral aneurysmal dilatations. And yes, we are waiting for the reports. So I would request my seniors and panelists to please opine upon the management of the patient.
Thank you, Dr. Dhiren, for presentation with such a long follow-up. But it seems to me that your patient is a steroid responder because whenever you give the steroids, your IOP goes high for the patient. So you have to be careful regarding this steroid response. Otherwise, for the retina, I will advise the other panelists to go ahead and discuss the case.
My question towards Dr. Vivek: is there a role of RT-PCR coronavirus in such sort of cases? Have we carried out the RT-PCR?
But this was in 2018, sir, when it started.
But it is up to December 2021.
Doesn't have fever. The patient doesn't have any of the signs of COVID. This is for me. This I would keep a differential diagnosis of adult onset coats in this patient, because this is not a case of vasculitis. This is a very typical case of peripheral aneurysmal dilatations, and the first choice of treatment for me would have been a good sectoral laser in that case, in that area, because that would have treated those aneurysms. If if I'm not still getting the response, I would have done a cryotherapy to destroy all those aneurysmal areas. Such cases of adult onset coats can be progressive, and slowly they can involve rest of the retina, but usually they respond very nicely to good properly done laser. And if it is progressive, then sometimes you need to do surgery and remove those things and do laser from inside also.
If I can just make an observation, beautiful presentation and beautiful follow-up. I thought, like, what you mentioned, that peripheral sectoral laser. So this is something that's very important. And if you have the opportunity to use a Optos angiography, Optos DFA, or a fundus fluorescent angiogram, wide field angiogram, then that is something that's going to give you a lot of information. So you will be able to see where the peripheral dilatations are, and if there are any ischemic areas, and do a focused kind of laser. And one thing is certain, that as you have also mentioned, that there has been episodes of vitritis also and vitreous hemorrhage also. So vitreous hemorrhage per se means that there are areas of leakage which are happening, and once in a while they bleed. So it needs laser. That's one part to it. And now you have a difficult situation because steroids are kind of raising the IOP. So maybe you can kind of tide over the situation with a little steroid and anti-glaucoma medication. But having said that, I think you also need to go ahead with some immunosuppressants, maybe azathioprine. I mean, like that is for starters, and then maybe scale up the ladder. And like you mentioned, PNK and a detailed investigation has to be done in such a situation, so that we can get to the bottom of this problem.
Any other panelists want to comment?
I would I would also agree with Vivek that this looks more like a Coats disease. So the management initially would have been laser or sectoral laser, and then wait and watch, because the only confounding factor is the vitritis. But the initial picture at presentation, that shows quite a clear picture. So like not much of vitreous haze. So that I also, my diagnosis would go more in favor of Coats disease. And because it is recurrent and now it is also increasing and involving more quadrants of the retina, the exudation. And besides, aneurysmal dilatations are also there at presentation, as well as Dr. Dhirendra said that they are increasing. So I think management would be laser, anti-VEGF and cryo mainly.
If Dhiren, you can go back to, if you can put your angiography slide again.
Yes. So
it's
we
actually the
also
clinching diagnosis is there. Yeah, you can share your slide of angiography.
Yes.
That's a very clinching slide because there is no signs of vasculitis in that picture. It is only aneurysmal dilatation and subretinal fluid is there. So this is only angiography.
Yes.
Yeah.
Yeah.
So you see these vessels are, these are, aneurysmal dilatations. Previous to this, you go back the first angiography slide. Yeah. Yeah, you can see, in the next slide, maybe you can see all those aneurysmal dilatations. So, you can give steroids. Obviously, the steroids help in stabilizing the membranes and vessels and reduce the exudation. But the treatment you will have to treat all these aneurysms. Yes, and now the situation you are in, I guess with counting finger vision, with vitritis, with cataract, you might have to go for surgery and treat these lesions. And if you think that there is signs of inflammation in the eye, and it is not because of exudation and it is because of vitritis, then you might as well, use immunomodulator therapy.
Yes, sir. So our first differential was also Coats disease or Coats disease with vasculitis. We did a sectoral laser, started the patient with steroids. But again, Coats disease usually occurs before the age is between 8 to 16, again with female preponderance and all. And vasculitis is not that common in Coats disease. So
in this patient, if you see, there is no perivascular sheath in the picture. There is no perivascular sheathing. There are no signs of vitritis. If you see this, you will not see any signs of vitritis. This is an aneurysmal dilatation. Had it been associated with a thicker vessel, feeder vessels, then I would have gone in favor of von Hippel-Lindau's disease. But since it is not there, I would like to, ablate this thing. And yeah, you can give steroids. I'm not saying that the steroids cannot be used, but then this thing is mostly predominantly exudative. You see all those lipids and cholesterol which is lying in the subretinal fluid. Yes. And these things also come into the aqueous and can be seen as vitritis,
And it is increasing also. And since media is not good and we cannot get a good angiography, I'll suggest to go for a cryo, at least if laser is not possible. And in fact, I'll suggest to go for a 360 degree cryo, take a chance of that. because this last picture, what you have shown, the color picture, the exudation is there in the superior this thing also, the latest one. Yeah, you can see that it is involving the superior sector also, not only on the temporal side. Means it is progressing, so you have to go for a good ablation, maybe whether you can get with LIO. If it is not possible, go with the cryo, and then do a cataract surgery or whatever with the if more laser is required, can do a cataract surgery, then do some laser. But definitely it is not simple vasculitis. I agree with that.
Yes, sir. Cryo is what we have advised the patient now, sir.
If I make comment, yeah.
Yes, Dr. Santosh.
Yeah, I totally agree with Dr. Vivek. It's one of the most typical features of a adult onset course. And if you look at the FA picture, there's not this leak not only in the temporal quadrant, even in the superior nasal and superior quadrant also. The leak was earlier there, even at that point of time. So now looking at the picture, I would personally, I would suggest mostly a media clearing surgery. Vitrectomy would be ideal. I mean, if it doesn't subside with anti-inflammatory therapy for some time. And a combined surgery would be ideal, though the patient is 20/21, because ultimately it might lead to a complicated cataract and no view, you can't treat anything, you can't do anything. So need to be a little aggressive now since there's a recurrence.
Thank you. Thank you so much. With this, we move ahead to our last case presentation by Dr. Nazia Sheikh from GMC. Your voice is not clear. Your slides are visible.
Slides visible?
Yes, your slides are visible.
Good
but
evening,
then
everyone. My face is of
your noise, your voice is not clear. Maybe you can shut down your video and then put the slide into the slide share mode and go ahead. Yes, you can go ahead.
Good evening, everyone. My disease of weakness of multifocal CSER, a clinical dilemma.
You can stop
the cases of a 20-year-old female.
Dr. Nazia, your sound is not clear. Either there are two instruments logged in, or you can stop your video from your end so that your image is not there, but the PPT will be there. Yes.
The cases of a 20-year-old female student came with a chief complaint of diminution of vision since 4 days. Patient was apparently all right 4 days back when she noticed diminution of vision, which was and was associated with headache. Diminution of vision was preceded by fever, which lasted for 2 days. There was no history of previous similar episodes in the past, no history of ocular trauma or surgery, and no history of COX or COX contact. And the patient is not a known case of diabetes. On general examination, patient was conscious, oriented to time, place, and person, and febrile and this was 70 beats per minute, and the blood pressure was 120/76 millimeter of mercury. On systemic examination, examination of cardiovascular, respiratory, abdominal, and central system within. On ocular examination, the vision in right eye was 3/60, improving on pinhole. In left eye, the vision was 4/60, which was not improving on pinhole, and the rest of the examination was within normal limits. In the fundus, the risk finding in both the fundus was within normal limits, and in general fundus there were multiple lesions, elevated lesion with subretinal whitish spots, and multiple chorioretinal folds were visible. So based on the fundus finding, the cause of Koyanagi-Harada disease, a typical bullous multifocal CSER, sympathetic ophthalmitis, posterior acute posterior multifocal placoid pigment epitheliopathy, sarcoidosis, lupus choroidopathy, disseminated intravascular coagulation, and we went on to do with the investigation, the blood investigation of a complete blood count and renal and liver profile and CRP, ESR, RA factor were within normal limit. PT-INR and APTT was also within normal limit, and chest X-ray was within normal limit. OCT findings showed multiple serous retinal detachment due to accumulation of subneurosensory fluid with fibrinous septae. On FFA, on the initial, multiple pinpoint leaks at the level of RPE in the initial phases were visible that pulled into sensory retinal space in the late phase. Based on the clinical finding and the history and FFA and OCT findings, we considering the possible cause as VKH or multitypical presentation of CSER, we started the patient on a systemic steroid under close watch. Patient was started on IV methylprednisolone pulse therapy for 3 days. And after 3 days, her visual acuity fortunately improved to both eyes 6/36. Patient was continued on tapering days of systemic oral steroids, and after 2 weeks, her multiple retinal detachment was reduced to serous detachment at the macula. So patient was kept under close watch, and after 6 weeks, the patient's visual acuity improved to 6/9 in both eyes. Acute phase, diffuse inflammation and serous retinal detachment. There are high chances that these retinal detachment can have a presentation of CSER. There are case reports by Kang et al. And Lee et al., which where such atypical and bullous CSER was exacerbated due to systemic steroid therapy. There are studies which report CSER as a possible complication in patients treated with systemic steroids for VKS disease. Thus, to conclude, a multimodal approach is necessary in diagnosis and follow-up of such patients. Systemic corticosteroids acts as a double-edged sword in such patients, though it is a part of treatment protocol in the patients with inflammatory etiology such as VKH, it has the propensity to exacerbate CSER. Thus, it is always recommended of the patient to rule out CSR and also possible secondary CSR in these patients. And though there are studies comparing OCT findings in these two studies, diseases, further research warranted in this direction. Thank you.
Thank you, Dr. Nazia, for your case presentation. Now case is open for discussion. Coincidentally, all the cases are nearly same. Dr. Chakravarti.
Yes, I agree with you. The cases share a similar kind of a picture. But having said that, I think a very interesting case again, and I think we also see a lot of VKH here, and many of them are kind of not really complete VKH. But I think we need to be careful about doing the right kind of investigation, like you showed, pinpoint leaks on FA. So I think that's the way forward. But you also, at the same time, just seeing a case with bilateral uveitis or pen uveitis, one shouldn't jump into considering VKH because you have to rule out other causes like TB, etc. in such situations, especially in our country. I think that's my take on the case.
Thank you, sir. Any other panelist wants to comment?
Yeah, nice presentation. Looks like more like a typical VKH presentation, which we usually encounter. One thing I would like to add is to kind of have a tab on, at least do a BP check initially to start with in such cases. Sometimes even the top end hypertensive retinopathy also at least to some extent. I mean, though it's not very typical of a weak age, if you start on such a patient on a systemic steroid, though you would be taking a physician clearance, so it can land up in other issues, which we had an experience. So that's just one point. Otherwise, the OCT signs and all, FA, these are very typical. The membranous exudation, the subretinal and intraretinal reflective material contact signs. So these are typical points of leakage.
Any other comment? So,
I'd like Ashish to comment on this because this is from my institute. So I would be biased, but I'll definitely like to make a comment. And there are multiple causes of multifocal, multifocal CSR or multifocal serous detachments. One of them is multifocal CSR itself. Then you can also have sympathetic ophthalmitis, but all those conditions were ruled out in her history, in the history of this patient. And so the only other cause that would be present, you could see a little bit of hyperemia of the right eye disc, so with some choroidal lesions. So APM-PPE is also one of the differential diagnoses, though rare. But again, that was ruled out on angiography because APM-PPE would have, hypofluorescent lesions which become hyperfluorescent in later stages, unlike in this phase where you have multiple pinpoint focal leaks. So this is kind of typical, of VKH, but not so typical again because the associated signs of VKH were not there. So this would fall into an isolated VKH. VKH can be classified into various categories, in which one has a typical VKH and one has an isolated kind of VKH where you don't have the systemic findings, though they can appear later also. This might be a first feature, and then later on vitiligo and sensorineural deficits and other things can come into picture. Or this might be an isolated VKH, which previously was known as Harada's disease.
Dr. Ashish?
I think in such cases, the most important thing is to decide whether to start steroids or not. So as Dr. Santosh said, the first thing would be to rule out hypertension. And in this case, basically, she is a female. And so that goes more in favor of inflammatory diseases because the CSCR is more common in males. And I think presence of cells can can point towards an inflammatory etiology. And then basically, once you have decided the probable diagnosis, then you can start steroids. So it was managed very well that way. So I have nothing more to add to that.
Dr. Chawla?
Yeah, the nicely managed case more looks like an inflammatory because of the other eyes also disc is hyperemic, so more in favor of inflammation rather than the CSR. So nicely managed and nothing new to add. All panelists and everyone has spoken well.
I think with this, we can come to a closing of this interesting case discussions. And really, it was interesting because all the cases were similar presenting features, but then different diagnosis. So excellent discussion. For vote of thanks, I will invite Dr. Javed Singh Bindra. Dr. Javed? I think some network issues. Dr. Lalit sir? Dr. Lalit sir, can you do the favor?
Yeah. So I'm actually thankful to all my speakers, particularly Dr. Chakrabarti from this eye hospital, Dr. Santosh Gadde from the very good the talk he has given, and our panelist, Dr. Gajendra Chawla, Dr. Vivek Som, Dr. Ashish, and case presented by Dr. Ridhima, Dr. Paresh, Dr. Fazil, Dr. Nazia, and Dhirendra. I'm actually thankful to everybody who has participated in this webinar, and our Dynamic Secretary, Dr. Vinita Ramnani, and Clinical Secretary, Dr. Jaiveer Mendra. Thank you to all. Thank you.
Thank you so much. Thank you, everybody.
Thank you so much.
Thank you.
Good night.
Thank you.
Thank you.
Thank you. Good night.
Thank you.
With this
Good night.
note, we will stop here. Thank you so much.
Bye. 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 Everyone.
Thank you, ma'am. Thank
Bye,
you,
Lalit
sir.
sir. Bye, Lalit sir. Bye, Chakravarti sir. Bye, Ridhima.
Bye.
Bye,
Bye.
Santosh
Bye,
sir.
everyone.
Bye.
Bye,
Good
Santosh
evening.
sir.
Good night.
Vivek,
Good
bye.
night. Bye.
Lalit sir, bye bye. Good night.
Good night, everyone. Bye-bye.
Good night.
Good night.
Good night, Dhiren. Nice case. Shavir, good night. आ
Good
गया
night,
तेरा
sir.
वोट ऑफ थैंक्स ललित सर ने दे दिया
हाँ सर,
शाबिर
सर पावर कट हो गया यहाँ पे।
तू
Right,
तो
sir.
कट नहीं हुआ ना गुड
नहीं नहीं
चलो
सर।
बाय बाय
Okay, sir.
बाय
Take care, sir. Bye.
गुड नाइट गुड नाइट